This is a kind of a tough job because what we're talking about is essentially transitions, and it depends on what you want from the pharmaceutical sector. So I've posed these questions about what is fair, what is prudent, what's efficient, who wins and who loses if we go to something like a universal Pharmacare program. And first, the nature of the sector is part of the problem, right? Because it's this funny hybrid of a public good and a commodity. And to the extent that it's a commodity, it's extraordinarily profitable. And the fact of the matter is we have an equilibrium now, however bizarre, whereby the most profitable industry in the world is the pharmaceutical industry, and a great deal of that profit derives from an extensive, remarkably high marketing effort and effective one, and also a considerable, lamentable part of the profit comes from off-label use. Secondly, it's an economic model that does, on the other hand, have its own peculiar logic, and it has reached a state of equilibrium, even if it's not the equilibrium we want. Due to a historical accident, and I would say a failure at the dawn of Medicare, it got left out. So the first thing I would say is that Canada is an outlier among countries. We have to realize that Canada covers a lower proportion of prescription drugs than just about any OECD country. So we're not normal. We're abnormal here. Secondly, we have had an experience with Pharmacare. My province, from 1975 to 1987, had a first dollar coverage, 100% Medicare program for which you only paid a dispensing fee. Everything else was free. The program was abandoned in 1987 for a number of reasons. The fiscal situation had turned south, but also annual cost increases were enormous. So there is moral hazard in setting up a national pharmacare program without reasonable controls, which we did not have at the time. But times have changed, and I think the prospects are a lot better. So you have to figure out what problems you want to solve, and the preoccupation of this conference has been the main problem we want to solve is lack of access for people, which is, of course, a noble goal. A problem I want to solve is overutilization, which is enormous. This may not be up-to-date data, but 15 years ago, 20% of elderly admissions to hospital were caused by an adverse drug event. When you take 5 or more drugs, your chances of an adverse drug event go up exponentially. The typical senior in this country has 9 to 11 prescriptions. This is an enormous problem, and rightly or wrongly, Pharmacare, universal Pharmacare, won't help it unless it is accompanied by vigilance, analysis, improved prescribing, and so on. So where do we want to go here? And it strikes me we have to figure out what problem we want to solve and which problem we will incur when we solve them. So a universal, more or less, Pharmacare program would certainly solve the problem of access. It will create, or it may create, other problems. And the question is, are those problems worse than the ones we have now? I would argue no. And secondly, do we have the wit and the experience to solve those problems so that we could actually pull this off? The other dilemma is that if we were starting from scratch, it wouldn't be that difficult. We could probably just take the best of some other Northern European country's system, probably cover 80 to 90% of drug costs publicly, and we would absolutely farm out our negotiation to New Zealand. And we would be fine on all counts. But so the devil is in the transition. How do you move from the house that we have built ourselves, which has a shaky foundation and a badly designed set of rooms, to the house we want? And I look at this as, what are the winning conditions? How could we possibly pull this off given the various stakeholders? And I'll just go through these very quickly. First of all, for providers, doctors and pharmacists, I think doctors would win immensely with universal pharmacare that is supported by an intelligent system that profiles their practices and allows them to see what the prudent prescribing is, where the adverse events come, and so on. And I think reference-based pricing and practice profiling have been enormously successful policy innovations in Canada to the extent that they've been implemented. I think it's a different and a troublesome issue for pharmacists. I think pharmacists are the peculiar profession in Canada, or sort of in the vortex of the moral dilemma. Are they the back part of the giant store retail outfit like London Drugs and Shoppers, where the pharmacy is almost a lost leader in a way of getting you in the store? Or is this a profession that its first duty is to the public? Its duty is not to the pharmaceutical industry itself. Its duty is to the health of the public. And its economic model is not based on further and further consumption of drugs, but on adding value to the therapeutic regime. It's a profession with a dilemma. I've written about this elsewhere, not universally loved by the profession itself, but it is a dilemma, and I think we have to confront it. What is pharmacy all about in this country? What about government? Government is wary of runaway costs, and government historically has a reason to be wary of runaway costs, but government also uniquely has the capacity to control those costs in two ways. It can add intelligence to the decision, to the situation by ensuring that drug consumption patterns are evaluated, professionals are engaged in their prescribing behaviors, and everybody has a lot more information about what is effective and what is not effective. And of course, government can also bargain effectively, and in Canada, as we have learned over this past day and a half, we're pathetic. As I say, let's take some lessons from a country of 3.5 million in the Southern Hemisphere about how to negotiate drug prices, and it's a win-win all around. But the other dilemma for government in these neoconservative times is that government has systematically reduced its tax base in this country. And it would probably have to raise taxes if it implemented a more or less universal Pharmacare program. And that is a question of political philosophy, and that has to be worked out in the political dilemma. The rational case is easy. The political case is somewhat difficult. Employers and employees particularly have an interesting stake in this. Again, we are hostage to what is known as path dependency. So since we have a lot of employer-based drug coverage, and it's in the middle class primarily and the upper middle class, most people in the country don't think about Pharmacare very much. The people who actually need the Pharmacare aren't a powerful constituency. And when it's not a middle class problem, it becomes a much difficult political dilemma to mount a huge interest in having another government program in an era that more or less denigrates government that would be in the general public interest. So that's a political mobilization problem, and it's also an insight problem. And the economic case I would make is that for employers, getting out of having to provide pharmacare and pharmaceutical benefits, which as we've learned in this conference, they don't actually invigilate very much because they don't want to piss off their employees, is a real problem for them. It's an economic tax on labor mobility and on an efficiency of production to have a pharmacare program that isn't central to what you do. So removing from business the burden of having these benefits programs is actually an economic benefit, would be a huge economic benefit to Canada in my view, and I think that's the kind of marketing that you would make of this phenomenon. For private insurers, I'm afraid there is no win in national pharmacare because, by definition, you'd get rid of most of them. I'm sorry, there are casualties in any sensible public policy, and that will be one of the casualties. And I don't see a way to square that circle. There will still be some small market, I predict, for that, but I'm afraid that that's just the way it is. So let's look at pharma itself. And as we know, the pharmaceutical economy worldwide is a very, very unique and peculiar beast. Many of its profits stem from behaviors that we wouldn't consider entirely admirable. If you look at the history of fines, the poster child company being Pfizer over the last 10 years, that writing off $3 billion of fines is just the cost of doing business for off-label marketing and all sorts. It's not a happy situation, and I'm not beating up pharma for this. I'm just saying we have a funny equilibrium that we need to wean ourselves from here about the production function. And when you have an essentially high-risk private sector, multinational industrial structure that is supposed to be providing a health needs-oriented public good, where innovation is unpredictable, where you may have rather dead periods of innovation that we're going through now, something doesn't add up here. It's very difficult to reconcile all the interests. So I think there has to be a transition in the way we organize pharmaceutical innovation, sales, and profits worldwide if we're going to have a well-aligned public interest and private sector market here. And I don't know that that's going to be easily possible, because I've talked to pharmaceutical people about this, and they will tell you in private moments, look, we know that this is a house of cards. It's extremely profitable, and if we did the right thing from the public interest, our market cap would shrink by 75%. I'm not making light of this dilemma, but it is a huge dilemma in all of this. So let me conclude with, with how we might do this and what are some possible measures to make this possible. Well, one thing is, one of the reasons that the pharmaceutical sector is so peculiar is that it spends from 20 to 40% of its revenues on marketing, which of course gets passed on to the consumers in the form of costs and has the more sinister impact of encouraging off-label and excessive use. So to me, it would be a reasonable public policy to limit the tax deductibility of pharmaceutical marketing expenditures to about 5%. They can still spend more if they want on marketing, but I don't think I should subsidize it with my tax dollars. Secondly, I think it would be interesting if we could devise a scheme that had differential tax treatment for the R&D costs and everything else surrounding Me Too drugs as opposed to genuine innovations. Now, that's conceptually easy to say, probably tricky to do in practice, because what is the distinction between a Me Too and a genuine innovation? It will be a continuum. But if we want to send signals to pharma to quit dining out on Me Toos, we have to give them some incentive to go towards something that is more genuinely innovative and high risk. And I think we could probably do something with the tax system. Third, and I think it was suggested this morning, I don't think it's a bad idea to set up a Crown Corporation on R&D for two reasons. One, I think it would be an interesting way for universities to partner with another public sector agency in order to start developing some drugs on a public interest epidemiological perspective rather than just another competition in a worldwide market. And secondly, I think it would be a less ethically fraught way for academic researchers to get involved in drug development without having to worry about co-opting of the enterprise and having to be business people who are really have to be vigilant about what is the relationship between the basic science innovation and the production of new products. I don't claim this would be easy, but I think it would be an interesting little thing. And I think a consortium of universities in North America, many of which in the States have very large endowments, to get involved in this area could be a win-win proposition. Another idea, it strikes me, is we need to decouple, and we need to somehow include pharmaceuticals much more into decision-making as competitors with the rest of health spending. So when you sequester pharmaceuticals and give them their own insurance market and their own production and sales avenue, it tends to privilege the sector. And we may be to the point where we are over-reliant on pharmaceuticals compared to others. So how would you get physicians involved in this? To me, I think we should consider, if we're going to have Pharmacare, some models of medical organization where you bundle medical and ancillary services with testing and with pharmaceuticals, and say you've got a global capitated budget. You guys decide on how much you're going to spend on drugs, but at least it gets everybody on the same page in terms of prudent use of drugs, improved prescribing, and to try to focus on the drugs that are the most useful and eliminate some of the expenditures that are less useful. I don't think it's very helpful for physicians not to be involved in this game. And I think that's one of the great hazards of the way we've organized it now, is that physicians don't actually have to care much because it's not part of their budgets. And there are lots of reasons and lots of marketing forces that would suggest that they would overprescribe. And finally, I think what we need to do is, as I mentioned earlier, launch a national conversation on the role of retail pharmacy. I think retail pharmacy could be a great force for good, but it is very difficult to decouple the retail pharmacies as they're organized around chains from the larger economy of the store, rather than the professional duty to be the stewards of the public interest in having prudent prescribing. I think I've written about this before. This is a dilemma for the profession. I don't think it's easy to solve, but I think that conversation has to take place. And if we could put most of those pieces together, I am reasonably optimistic that we could look a lot more like other countries that fund 70 to 80% of drugs, we could do a much better job on the purchasing. We could add a lot more intelligence and analysis to the effectiveness of prescribing, and it would be a win-win for Canadians. And the biggest economic payoff, I think, in the short run would be to relieve employers in corporations of the need to be concerned about this. So I guess I'd say, in conclusion, I think we can get there. There are more winners than losers if we do. Some of the people who would perceive there would be losers will fight back on all of this. We could get a lot of, frankly, dead overhead out of the system And if we bargain harder on prices, it could be a truly win-win-win. And I think it's going to be a question of whether we have the will to overcome our inertia that was really born of a peculiar decision about what was in the Canada Health Act all these many years ago.